which is the pediatric uveitis. So as you know, the uveitis is classified according to the anatomy into 3 locations or 3 main entities, or let's say it's 4 entities: the anterior uveitis, the intermediate uveitis, the posterior uveitis, and the panuveitis. So what are the causes of each? Regarding the anterior uveitis or the pediatric anterior uveitis, it can be due to a wide range of reasons, of course. The most important is juvenile idiopathic arthritis, or infections, or trauma, which would be one of the commonest causes. Juvenile onset spondyloarthropathies like ankylosing spondylitis and Reiter syndrome, sometimes they can happen at younger age. Early onset sarcoidosis, or what's called the Blau syndrome, and the masquerade anterior uveitis, like the patient will have a posterior segment pathology like a tumor or retinoblastoma or leukemia or lymphoma, and it will masquerade as anterior uveitis. So again, we will cover the most important relevant to pediatric ophthalmology now, and we will continue the other diseases in the uveitis lecture. So the most common cause of chronic anterior uveitis is the juvenile idiopathic arthritis. So what is the juvenile idiopathic arthritis? It is a disease characterized by idiopathic arthritis in patients who are young, less than 16 years of age, and last for at least 6 weeks. These diagnostic criteria are very important. Again, idiopathic arthritis, it is present in young children, less than 16 years old, and last at least for 6 weeks. You can see this is the arthritis, and this is the arthritis. So what will be the incidence? As I told you, it is the commonest childhood anterior uveitis, occurring in like around 1 to 1,000. And there is little or no correlation between the ocular and joint inflammation. This, if the joint is very inflamed, this doesn't mean that the eye will be inflamed as well. We will see now that those patients are characterized by a white eye. So there will be minimal ocular inflammation. Okay, so what will be the types of patients with juvenile idiopathic arthritis? It can be classified into 3 types: the oligoarticular, polyarticular, and Still's disease. So what will be this classification based on? It will be based on the joint affection and the systemic disease affection. Oligoarticular, sometimes referred as to polyarticular, in which there is involvement of 4 joints or less. The polyarticular type, there will be involvement of more than 4 joints, while the Still's disease, it is involvement of any type, like, or any number of joints. Oligoarticular tend to be more in the early childhood, while the polyarticular starts in the late childhood. Still's disease occur at any age. Sex is also very, very important. In the oligoarticular, it is by far more common in females. Like around 80% of cases are female and only 20% of cases are males. So the ratio will be like 5 to 1. Polyarticular is still more in females, but with less ratio, like around 60% of patients will be females, while around 30 or 35% will be males. In the Still's disease, there will be the equal female to male ratio, or even it will be more in males. So these ratios are very important for the exams. Iridocyclitis also very important for the exams. You see the least joint affection, which is the oligoarticular, with the youngest age, have the most higher incidence of uveitis. Iridocyclitis is 20% in cases of oligoarticular, which will be the highest percentage of development of uveitis in a patient with juvenile idiopathic arthritis. Very important. So if you have a patient with minimal joint affection and younger age, don't say that, okay, he is still young and no joint, there is little joint affection, so it is unlikely that they will have uveitis. No, the reverse will be the true. Those will be at highest risk of developing uveitis, and they will have no associations. Regarding the polyarticular, it can occur to 5 to 10% of patients only will present with uveitis. So the polyarticular will be less severe than oligoarticular or less incidence of uveitis than the oligoarticular. Still disease, luckily, it will be the rarest to have uveitis. But on the other hand, they will have systemic associations, including the high fever, rash, organomegaly, and the polyserositis or inflammation of the serous sacs. Okay, everything here is important and asked in the exams. Every word, every letter here is very important. So what will be the clinical presentations? Those patients with chronic uveitis, usually the uveitis start after the arthritis. The kinds of uveitis is chronic and non-granulomatous. So it doesn't show granulomatous keratotic precipitates, but it shows only small to medium size keratotic precipitates. The striking feature here is that it is white eye. So those patients usually don't complain of pain, don't complain of redness, or the mother or the father don't notice any abnormality in their eyes. That's why those patients should be screened in order to detect them, because those patients will just lose their vision very silently. Posterosynechia is common in long-standing cases. So what can we see here? Those patients have posterosynechia with adherence of the iris to the lens, and there is a band-shaped opacities in the cornea. This is a band keratopathy, and this band keratopathy is one of the causes of loss of vision and amblyopia in those children. So what are other causes? Those children can be present with band keratopathy, cataract, glaucoma, cystoid macular edema, chronic hypotony, and phthisis. So why, you may ask yourself, why? How come that they will have glaucoma and hypotony at the same time? No, it is not at the same time. They initially will present by glaucoma due to inflammation. The uveitis will cause thickening of the aqueous. This aqueous will not be able to pass through the trabecular meshwork, causing secondary open angle glaucoma to the uveitis. Later on, with the inflammation, this will result in formation of membranes, including cyclitic membranes. These cyclitic membranes will be adherent to the ciliary body, causing contraction. This will causing cyclodialysis or ciliary detachment. So the ciliary body, which will be producing the aqueous, will be detached, leading to hypotony and phthisis eventually. So you see, this is very catastrophic destiny for this eye. So in order to have a high index of suspicion about those patients, what are the risk factors that make those patients more liable to develop uveitis? These risk factors can be summarized into these five issues or five manifestations. First of all, if this child has anti-nuclear antibody positive, so if you did anti-nuclear antibody assay and you found it positive, so this makes them at particular risk. The female gender is also at a particular risk. The oligoarticular, as we mentioned, if the presence of 4 joints or less is at particular risk. The presence of human leukocytic antigen DR5 is at particular risk. The young age or the early onset of age less than 6 years is also at particular risk. So to remember it, remember Anna female 456. Anna female 456. These are the criteria for a high risk for development of juvenile idiopathic arthritis. So for those patients, we need to do screening. We will talk about the how to do risk stratification for those patients in the uveitis lecture. But from now, for patients with high risk, we should screen them every 3 months. For patients with moderate risk, we screen them every 6 months for development of uveitis. And for patients, no, this is not 3 months. This is 1 year. For patients with low risk, we can screen them every 1 year. Okay, so this is all. This is for anterior uveitis for now. As I told you, for other reasons, we are going to discuss them in the uveitis lecture. The next location for uveitis or for inflammation by the in the uveal tract will be the pars plana or the intermediate uveitis. Intermediate uveitis will account for 25% of all cases of pediatric uveitis. 75% will be bilateral, as you can see here, this patient, bilateral uveitis. And those patients can sometimes present with non-traumatic hyphema. You will see them, they have parahyphema, but there is no history of trauma. They will have retinal vasculitis, vitreous opacities, what's called snow banking and snowballs, cystoid macular edema as a cause of loss of vision, and they can be also secondary to multiple sclerosis as an also important cause of intermediate uveitis in the pediatric age group. Dr. A, is uveitis in children is rare? Is that rare? In practice, I haven't, I have just young patients 20 years and more. Yes, so let me tell you, if we are classifying the uveitis between the children and adults, what will be the percentage? So it will be like around only 10 to 20% of patients will be the pediatric, but around 80 or 90% will be in the adults. So yes, the uveitis is rare in children. Okay. Okay, so this is for the intermediate uveitis. And finally, the posterior uveitis can also be having differential diagnosis, including the toxoplasmosis, toxocariasis, syphilis, HIV, Lyme disease, juvenile xanthogranuloma. We will talk about it in the pathology, intraocular foreign body, and sympathetic ophthalmia. So we will talk about mainly on the toxoplasmosis and toxocariasis now, and for others we will leave them for the uveitis lecture. So in the toxoplasmosis, as you know, it will be infection by the parasite Toxoplasma gondii. This parasite will cause retinochoroiditis or posterior uveitis. So if you are wondering if is this common or not, well, actually yes. The toxoplasma or toxoplasmosis is the most common cause of posterior uveitis. So 25% of patients with posterior uveitis are due to toxoplasmosis. This will cover the pediatric and the adults. So all of them, 25% of patients with toxoplasmosis or 25% of patients with posterior uveitis are due to toxoplasmosis. Of those, 98% are congenital and only 2% are acquired. And toxoplasmosis is the most common cause of pediatric uveitis. So 50% of posterior uveitis in children. These numbers are very important. So commonest cause of posterior uveitis by far is toxoplasmosis. Commonest cause of pediatric uveitis is toxoplasmosis. Commonest cause of posterior uveitis in children is toxoplasmosis. Okay. So speaking about toxoplasmosis, what will be the causative organism and what will be the life cycle? Sometimes it's asked in the exam. Okay, so here we have the cat. The cat is the definitive host for the toxoplasma. The cat will have the organism of the Toxoplasmosis gondii in her guts, and they will shed the oocyst through their feces. And this oocyst will have different destinations. Sometimes they will be ingested by man, like if they are present, they contaminate the soil. So if they can be accidentally transferred to man, or they can be ingested by rat as an intermediate host, which will be later on ingested by the cat as a definitive host. Or these oocysts present in the soil can be ingested by cattle or sheep, and then they will be later on ingested by man. So if there is uncooked meat or undercooked meat ingested by man, this oocyst will be transferred to the man. Or if the man is, or if a woman, a pregnant woman is present, is having a cat, and this cat is shedding this oocyst, and this oocyst is transmitted accidentally to the woman, this pregnant woman, this woman can pass the organism toward his baby. So this will result in congenital toxoplasmosis. Okay, so this oocyst later on will transform into the tachyzoid. It will transform first into bradyzoid, then tachyzoid. This tachyzoid is the form which is responsible for inflammation. This also has been asked before in the exams. And in the congenital infection, there is a transplacental transmission of the toxoplasma. So this will be how the baby is acquiring the congenital infection. The mother will be having the toxoplasma, and it will pass through the placenta to her baby. Acquired infection is just by exposure to the environments where the infectious organism is found, as we just discussed. So what will be the types or the clinical presentations of those of the toxoplasma? In the acquired cases, those patients will present initially by the general constitutional manifestations like rash, like meningoencephalitis, flu-like symptoms. But for congenital, we are talking about the general manifestations. So they will, when the toxoplasma is transmitted from the mother to the fetus, this can result in stillbirth, mental retardation, seizures, hydrocephalus, microcephaly, intracranial calcification, hepatosplenomegaly, vomiting, and diarrhea. So these are the syndrome of, there are like classic triad of signs associated with congenital toxoplasmosis, like chorioretinitis, inflammation of the retina and choroid, cerebral calcifications, and hydrocephalus. So this is the classic triad. So what are the other manifestations like microcephaly or seizures or hepatosplenomegaly? What will be the factor that will control what are the symptoms and manifestations of congenital toxoplasmosis? It will be the time. The time. When did the infection occur? Did it occur in the first trimester or after the first trimester? In the first trimester, this will result in more serious manifestations. So it will cause the hydrocephalus, like stillbirth, intracranial calcification, chorioretinitis. It will be more serious, causing more general manifestations. So the more early, the more the serious. Later infection can only have retinal affection. So later infection will be less serious, but it is more common due to well-developed placenta. So again, the early infection, more serious, but less common. The later infection, the more common, but less serious. And this is also very important for the MCQ exams. Okay, so regarding the clinical presentation of the retinal lesion, we said it will cause chorioretinitis. So what will be the presentation? Actually, it can take the different forms. It can take the form of a scar, or it can take the form of an active lesion. In case of a scar, it will present with inactive chorioretinal scar in the posterior pole, usually in the macula. Present with a scar with punched out edges and variable pigmentation, can be single or multiple, and usually is present in the macula in the close proximity to the optic disc. So this is a macular scar. It will cause diminution of vision, but if it is present in the macula, but no treatment here is required because it is just a scar. Or it can be present with an active lesion. In an active lesion, it presents as a focal, whitish, fluffy lesion, which is sometimes referred to as headlight in the fog appearance. You see, this is the vitritis. You can see the posterior segment details are hazy. This is because of vitritis. And in this vitritis, there is an active whitish lesion. This whitish lesion appear as very bright in the surrounding vitritis, giving the appearance of a headlight in the fog. This patient will be associated with granulomatous uveitis and vitritis. Sometimes both of them can coexist together, like the patient can have a scar from a previous insult or a chorioretinal scar from toxoplasmosis and another active lesion together. Okay. There is a specific case where the patients can be immunocompromised, like toxoplasmosis can occur. It is an opportunistic infection, so it can occur to patients with immunosuppression, like HIV patients. And the specific condition in those patients that, unlike usual, they will show minimal anterior chamber reaction and vitritis, minimal vitritis. Actually, because the vitritis is a sign of a good immunity. If there is vitritis, meaning that there is immune response to the organism. And those patients who have immune suppression, they don't have immunity. So they are unable to develop normal immune response. This lead to no vitritis. So sometimes they are asked you in the MCQ exam that say that HIV patients, they have severe vitritis. So you may be thinking that since the HIV, it should be a severe infection, so it should be a severe vitritis. No, the reverse is the true. That will be severe vitritis in normal immunity, but minimal vitritis in patients with impaired immunity. When we are going to discuss the uveitis lecture, I'm going to repeat this again. For patients with cytomegalovirus uveitis, they will have minimal vitritis, and the patients with acute retinal necrosis, they will have vitritis because they will have good immunity. Okay, so this will be a differentiating feature. So how can we diagnose a patient? Usually the diagnosis is clinical, but if in doubt, we can do PCR from a sample from the vitreous or from the anterior chamber to detect the organism DNA, or ELISA or immunofluorescence assay for the toxoplasma IgG or IgM. The treatment is mainly by antibiotics and steroids, but it has a specific indications. Not every patient, usually it is a self-limited condition, even if it occurs to adult and it will be away from the dangerous site. Don't need treatment. It will be just recover. The host immunity will just recover by itself. But we only do treatment for specific indications, like if the patient has very severe vitritis, or if the patient has HIV, regardless of the location or severity of the condition. And finally, if the patient has a posterior pool affection or a lesion near the optic disc or the major blood vessels, this will be an indication to treat to prevent a scar that will cause permanent visual loss. Wide range of drugs that can be used for treatment, antibiotics with systemic steroids to minimize the inflammation. So these antibiotics like clindamycin, sulfonamides, pyrimethamine, cotrimoxazole, azithromycin, and atuvacone. With most of these drugs can be teratogenic, and the clindamycin can be used safely in a pregnant woman. Okay. So this will be the toxoplasmosis. That I hope that it is clear. Another disease will be the toxocariasis. No much details like the toxoplasmosis, just a few lines that the toxocariasis is caused by another parasite called Toxocara canis, which occurs or which is present in the puppies or dogs who are, so they tend to be infecting the people who are having dogs or puppies, so they will harbor the Toxocara canis. The incidence, it is most commonly to be unilateral, and the clinical presentation will take different forms depending on the age. Like if it's present in the first years of life, like between 2 to 9 years of life, those patients will present with leukocoria or strabismus. So those patients will present with chronic endophthalmitis-like features. So there will be ocular inflammation, there will be whitish pupil, there will be strabismus, and those patients should be the most important differential diagnosis in those patients should be ruled out is the retinoblastoma. This is very important for of the child in this age group. Another differential or another presentation will be posterior pole granuloma. Like it happens when there is a granuloma in the macula, and usually present at older age group between 6 to 14 years with visual loss. So those patients will present with visual loss. Another presentation is the optic disc granuloma or optic nerve granuloma. So this is a granulomatous disease. It will cause granuloma, and granuloma can affect any location. It can affect the optic disc. So it will happen between 6 to 14 years old with visual loss, and the granuloma can be present peripherally. So this is a peripheral granuloma. And what is happening here in the retina? Then this is what's called dragging. It will cause dragging of the optic disc and the macula. This peripheral granuloma causing dragging of the optic disc and the macula. This will be fall under the differential diagnosis of a dragged macula, like what happens in familial exudative vitreoretinopathy or retinopathy of prematurity, or the incontinentia pigmenti, or diabetic retinopathy even, and sickle cell retinopathy. We will talk about that in the retina lecture. So this will be one of the differential diagnoses of a dragged disc or dragged macula. And in this case, those patients will need a vitreoretinal surgery. Diagnosis can be made by different methods like ELISA. Also, those patients will have high eosinophilic count, and the treatment will depend on the condition. Like if there is posterior endophthalmitis like picture, those patients may benefit from steroids to minimize the inflammation, and antiparasitics like albendazole, and surgical for patients with like posterior pole granuloma or peripheral granuloma with dragging. Those will benefit from Parsoplan vitrectomy. Okay, so this is for the uveitis, and let's now move to the final section of